Hey guys, this is Mubin. We're talking immunology. Today's lecture is very important. This is immune pathologies. What I have done is I've created the bigger picture of the immune system, the acquired arm of the immune system at least. And then what I've done is I've gone through various normal functions of the immune system, and once we understand the normal functions that we know actually already from previous lectures, then what I've done is I've placed various pathologies for wherever the defect is. So what I would recommend is that if you can take a picture of this this board, or if you can draw this board again in 3 rows, 1 row, second and third, maybe create a little bit more space in it where you can take notes for pathologies, and then we'll put all the pathologies on one place, and you can actually logically see that why a particular area, when that is damaged, then a particular pathology would appear. So having said that, let's do this. First of all, let's review the normal function of the immune system, and then we will create abnormalities by breaking various parts of the normal functions and see how the pathology occurs. So normal function, let's start from the bone. Bone makes the B cells and T cells. B cells get matured inside the bone, they go from pre-B to pro-B and then B cells. Pro-B cells start expressing the IgM on their surface, and then they become mature B cells that go and live in the lymph nodes. Now remember that a mature B cell that is sitting in a lymph node has IgM and IgD sitting on its surface, acting as receptors to trap antigens. And also remember that B cells can trap proteins, polysaccharides, nucleases, heptins and other such kind of antigens. On the other hand, T cells can only trap the protein or polypeptides as antigens. So this is the B cell. T cell, when they are released from the bone marrow, they go to thymus. So this is a T cell, it would go to a thymus. In the thymus, I know I've given the lecture before, in the thymus the T cell will be trained or educated or matured or selected for the right function. Once that T cell is selected, it would come out in the blood vessels again. From the blood vessel it would go and live in a lymph node. That may be a lymph node, or that may be a lymphatic tissue, part of malt or galt. So now the T cell is sitting in a lymph node, it is naive, it's not mature yet, it doesn't know what is its function in its life. B cell would also come and join, and so the lymph node would actually have the B cells and T cells both sitting in there. So that is still normal function. Now let's talk about couple of more actors in this one, macrophages and neutrophils. So that is the row here. Macrophages and neutrophil, what their function is, that they would engulf the pathogen, they would move it into a phagosome. From there they would combine the phagosome with the lysosome. Lysosome has gotten various kind of breakdown enzymes, digestive enzymes, which would break down that particular pathogen, and then that pathogen's fragments will be presented out on the surface, and the cell would act as a APC. Neutrophils don't act as APCs, but macrophages act as APC. Now within the neutrophil there is another very important thing, and that is the fusion of phagosome and lysosome. This happens in macrophages too. And number 2, oxygen burst. And what is oxygen burst? Oxygen burst is, we've talked about it before, that we create radical oxygen and then we create bleach, and that bleach is poured on the bacteria or pathogen, and that pathogen is fragmented or broken down. So in that there are a couple of enzymes that are really important, NADPH oxidase and superoxide dismutase, and then myeloperoxidase. These 3 enzymes are actually very important to understand or to take part in the respiratory burst to make the bleach. And of course this is the final pathway, this is where the actual breakdown of the pathogen occurs. So if this pathway fails, then the pathogen will arrest the pathogen, will combine it with the digestive enzymes, but we will fail to actually break it down. So imagine that there will be some problem here. So in this row we have phagocytic cells, that is neutrophils and macrophages. Over here we have reached up to the naive B cells and the naive T cells and the B cells. Now let's talk about a pathogen entering our body. Pathogen enters the body, neutrophil would pick it up, engulf it, phagocytose it, and then break it up and give the antigen fragments out. Similarly, macrophage can engulf it and present the antigenic fragments on an MHC2. Remember that there are 3 types of APCs, macrophages, B cells and dendritic cells. They can present the antigen So if you see here, here is a macrophage, they can present the antigen on their surface as part of MHC2 complex, although all other cells except RBC, all nucleated cells can also present the antigen on their surface with MHC1 complex, including macrophages and neutrophils. So MHC2 complex you are seeing here, MHC1 complex you are seeing here. This is a virus infected cell which has gotten the antigen, virus antigen presented on its surface with MHC1 complex. So now pathogen is in, macrophage picked it up, neutrophil picked it up. Now macrophage is presenting the pathogen on its surface. At the same time, what macrophage is doing is, here I am showing macrophage is releasing IL-12. This IL-12 would convert a T helper 0 naive cell to T helper 1. Remember, we also talked about IL-4 coming from the unknown cells that can convert a T helper 0 to T helper 2. So let's talk about this row first. This is the row for the cytotoxic killing. So now what happens is macrophage has the antigen presented, plus it is releasing IL-12. The T helper 0 would be converted into T helper 1 cell. T helper 1 cell now, remember it is connected to the macrophage, there is a co-stimulation here. T helper cell now will generate IL-2. Interleukin 2, what it would do is it would activate cytotoxic T cells. So this is the effector cell. Which cytotoxic T cell? Every cytotoxic T cell? No. The one that is connected with some sort of antigen. So if you think about 1 million cytotoxic T cells sitting in a lymph node or sitting somewhere in the tissue, many of them are just sitting alone, they are not doing anything, their T cell receptors are not occupied by any antigen. However, some of the T cells, cytotoxic T cells, have gotten, they have attached to the MHC1 complex on a pathogenic cell, a cell that has pathogen in it and presenting the MHC1 complex on its surface. However, these are not active yet. To activate them, they need the stimulation from the T helper 1 cells. That is why these cells are called helper cells. And so IL-2 will be released. That IL-2 when connects to the T cytotoxic, which has also combined on the other side with the MHC1, then this C cytotoxic cell would become active, and the activity, the result of activity is that it would release perforins and granzymes. These would poke holes and break membranes and kill the cell. Actually, perforins create the holes and granzyme go in the cell and cause apoptosis. So this cell which is infected with the virus would be killed by two mechanisms. That is why it is looking so sad over here. So this is the cytotoxic killing. The cell will be killed. This one is pathogen killing, where pathogen is taken and killed by a macrophage. Now let's go here. T helper naive cell sitting in a lymph node somewhere. Then comes IL-4. IL-4, when that comes and attaches to the T helper cell, IL-4 converts T helper 0 to T helper 2 type cell. T helper 2 type cell, when it is occupied by a B cell. So what happens is it is not occupied but rather presented by a B cell. So there is a B cell as well. Remember, B cell is an antigen presenting cell. So there is some pathogen present, of course, that is why this whole mechanism is running. So some virus, some bacteria, protozoa, fungus, something is present. That thing is also being presented by the B cell, right? And again, this is MHC2 complex, because B cell is a professional antigen presenting cell. So MHC2 complex is presenting the antigen to T helper 2. Here MHC2 complex are presenting the antigen to T helper 1. That is the difference. Now T helper 2, when that is combining with the B, it would also need a co-stimulation, and that is B cell has a CD40 ligand and then CD40 molecule, and T helper cell has a corresponding ligand molecule which is CD40L. There is actually B7 and CD28 as well, they are combined. So these are the co-stimulatory molecules. We've talked about them in our other lectures, so I don't want to talk in detail about those. It is important to know them here so we can create pathologies. In addition to the signals, T helper 2 cell would also release interleukin 4 and 5. The function of these two, we talked about that before. IL-4 class, which is a B cell, from releasing IgM to release IgE. So remember, IgM can be released by a B cell without the help of T helper cell. So this is important for pathology now. If we have antigens, a B cell can capture the antigens and then release IgM for antibodies to help to handle that antigen. However, if this B cell is going to produce IgG, IgD, sorry, not IgD, IgG, A and E, then this B cell need class switching, and that class switching signal is IL-4 and 5. IL-4 for IgE and IL-5 for IgA. So that is very important, and once the class switching occurs, the B cell would convert into a plasma cell. Plasma cell is nothing but is an active B cell which is making a lot of antibodies or immunoglobulins, and IgG, IgM, IgE and IgA are formed. Why not IgD? IgD is also present inherently on the surface of a B cell. Function unknown, mostly we say that this does work with the as a receptor as well. Okay, so this is the B cell or humoral response. This is the cytotoxic response. This is the innate response, although macrophage is not entirely innate. It would also now work with the acquired arm, and this is again very important. What happens is that once a T helper 1 cell becomes active, it does two functions to create cytotoxicity. One is that it activates the cytotoxic T cells that would kill the virus, bacteria, infected cells or intracellular pathogens or cancerous cells. On the other hand, the macrophage that was connected with the T helper 1 cell, T helper releases interferon gamma. Interferon gamma in turn activates the macrophage. That activation will up macrophage's functions. What are those functions? Phagocytosis, that is one function, and oxygen bursts or phagolysosomal digestion is the second function. So taking up the bacteria and killing them the frequency would increase. So now this macrophage, once it is active, will not only be a detector of something that is coming in, but rather it will become a machine that is chopping up the pathogens. Many students say to me that which intracellular killing increases. When the macrophage is doing the killing, other cells, what happens when the pathogens are sitting in there? Well, here's the thing, intracellular killing actually means the killing done inside the macrophages. So macrophages would pick up the cells, the pathogens that are intracellular, and kill them. So it is their function. So T helper 1 has caused two cytotoxicities. One is that or has caused killing of pathogen by two cytotoxic mechanisms. One is by CD8 and the second is the macrophage. Here the cell itself will be killed, here the pathogen will be killed. So these are the normal functions. Let's talk about the receptors and chemical things here. You saw that macrophage releases IL-12 that works on the T helper cells to activate them. So that is IL-12 receptor here, IL-12 released from the macrophage. Then of course T helper 1 releases interferon gamma. The interferon gamma has a receptor on the macrophages. Then T helper releases IL-2 that activates the CD8, plus it also activates the same T helper cell as well and helps it to grow. Then on the cytotoxic side we have perforins and granzymes, and of course there are receptors there. Over here there are CD40 ligand, B7, CD28 not shown here, IL-4 and 5 are coming here, so of course the receptors there. Plus note one more thing, with the T cell receptor is this. With the T cell receptor is there, T cell receptor is here, T cell receptor is here. There is a co-stimulatory molecule called CD3. So all T cells have gotten CD3 attached to them. Again, this is important for our pathology. The other thing to remember is that T cells also have CCR5. These are molecules or helper molecules, CCR5 and CXCR4. CCR5 are also found on the macrophages if you think, but this is important here. Why have I made them here? Acquired immunodeficiency, HIV pathogen actually virus uses these molecules to go into the cells and kill the helper T cells, especially helper cells, not the cytotoxic or others. So this is the molecules, interleukins, and then the various functions. Now let's create pathologies. Let's start from here. First of all, let's say we've gotten the B cell from pre-B to go to pro-B inside the bone marrow. Sometimes what happens is, so this is the Bruton's Agammaglobulinemia. What happens in that is that there is a BTK gene defect, tyrosine kinase gene defect. What that defect does is that pre-B cells cannot be converted to pro-B. Now what would happen? Think about it. Remember, we have talked about the functionality. Pre-B would become pro-B, and from there it is a mature B cell. In the Bruton's Agammaglobulinemia, pre-B cells will be found in the bone marrow, but they will not be converted into pro-B, so they will not be found in the lymph nodes. So the patient, mostly boys, because it is X-linked, they would be not having B cells. Now not having B cells, or lack of B cell, or deficiency of B cell would mean what? Less immunoglobulins. When there are less immunoglobulins, what does that mean? That means recurrent infections, especially with the IgA deficiency. There is going to be recurrent sinus infections, otitis media, and pulmonary infections. So you say to me that, hey, why do we really just talk about IgA? Why not the other deficiencies? Here is the reason. Pathogens enter our body from our surfaces most of the time. It is rare, or it is less frequent, that we get injury where something is pushed in from a cut or an injury of that kind, or a burn, but mostly they would enter from the sinuses. And if it is the IgA, I meant sinus surfaces, IgA is the one which is the protector of the surfaces. So when the IgA, let's say all the immunoglobulin went down, however, because IgA is down, that is the first defense that is broken down, and the pathogen would start attacking. So the attack would be recurrent sinus infection. So if you see here, I have put the areas where recurrent infections will occur. So this is middle ear, if you see ear and middle ear. So recurrent middle ear infections, sinus infections, this is the nose and these are the sinuses around this, and pulmonary infections, so these are two lungs and there are sinuses. So if you start from here, ear, sinuses, lungs, ear, sinuses, lungs. This is the Bruton Agammaglobulinemia. Why? Because there are no B cells, and that means there are no immunoglobulins. That means there is no G and no M and no E and no A. However, effect of A will be seen more easily, that would be seen by this. Okay, so that is the Bruton. So now let's come down here back. This is the B cell production problem. Let's go to the T cell and let's talk about T cell production problem. If the thymus is absent, and that happens, when does that happen? When the second and third pharyngeal pouches in the embryonic stage fail to develop, thymus will not develop and the parathyroid would go away. So when the parathyroids are not present, that means the calcium will not be present in the right amounts in the blood, and tetany would occur. So these patients would actually mostly appear or present to you with tetany or facial problems with tetany instead of coming with the infections. Now what would happen? This is the DiGeorge syndrome. If you take the chest x-ray, they would not have the thymic shadow. The thymus is not present. No thymus, no parathyroid gland. Second and third pharyngeal pouches are not formed. Why? Because there is a deletion of 22q11, chromosome number 22, short arm q, and then 11. What happens to these patients? So before we go there, think about it. If there is no thymus, there is no mature T cells. If there are no mature T cells, there is not going to be this function, cytotoxic functions. There are not going to be upregulations of activation of the macrophages. There is not going to be the activation of the B cells. However, think about it, T cell is not present, but B cell can detect an IgM, an antigen, and produce IgM. That is their independent function without the help of the rest of the immune system or the T helper cells. So that means B cell would still function, but they won't really do class switching, they would do IgMs. Thank you. Okay, so let's continue our immune pathologies. So we talked about Bruton and we talked about DiGeorge syndrome. So again, I'm not doing B cell only and T cell only. I'm going through the picture and putting the defects as we go through the sequence of normal function, and as we see the defect we can see pathologies. I think this is beautiful. Okay, so we've talked about B cell deficiency. Now let's talk about one more. Let's say thymus is present and the T cells are being produced. Now how does a T cell become active? Two ways. A naive T cell becomes T helper 2 when it is attacked or when it is stimulated with IL-4. A naive helper cell becomes T helper 1 when it is stimulated with IL-12. If IL-12 receptor are not present, IL-12 receptor deficiency, if that is present, that would cause what? Most common disseminated mycobacterial infections. What does that mean? Mycobacterium is intracellular, and intracellular pathogens are taken care of through this path. Neutrophils and macrophages, especially macrophages once the acquired arm works. So let's talk about that. Let's say there is the mycobacterium that came into my lungs. Actually I've worked in the TB ward, so maybe it may be in my lungs. So that comes into my lungs. What would happen is that T helper cells will pick up the macrophage would pick up the mycobacterium, it would break it apart, it would show that on its surface on MHC2 complex. T helper cell, it would release IL-12, IL-12 would activate the helper cells, they would come and attach, they would then release interferon gamma and activate macrophage. Macrophage activation would cause macrophage to start killing the TB cells or mycobacterium tuberculosis inside them. Also this activation would cause the macrophages to start making granulomas. Most of the intracellular bacteria or pathogens, fungi, which are handled by macrophages. So remember this one, the viruses are not handled by macrophages primarily. These are handled by cytotoxic T cells and natural killer cells. We are talking about bacteria and the fungi. Most of the intracellular bacteria and fungi would cause granulomas. Why? Because it is a macrophage that is taking care of them. When they are present in the macrophage and T helper cell are activating the macrophages, activated macrophage become epithelioid, they fuse with each other, they make circles, they make a body that is called granuloma. So that granuloma would be formed here. Now think about it. IL-12 receptor in the T helper is not present. Mycobacterium is sitting here in the macrophage. Do you think that this pathway would act? It will not, because we need T helper cell to become stimulated with IL-12 to become T helper 1 to then activate the macrophage. That is the IL-12 gamma interferon axis. That axis is not going to function. That would mean mycobacterium would live in here happily. Now one thing, there would still be some breakdown of mycobacterium. That is unactivated, inactivated macrophage, normal regular macrophage who is just trying to do APC function. In the APC function, macrophage really does very little work. In the activated form, it really kills the pathogens. So it would still be killing but really low, and that would cause granulomas and disseminated mycobacterial infection, because mycobacterium would break it and go through the whole body and run around. So that is the IL-12 receptor deficiency, mycobacterium. So let's continue going. Let's go to this row. B cell, humoral function. How does the T helper 2 cell function? IL-4 converts T helper 0 to T helper 2. T helper 2 cell then connects with a B cell that is presenting an antigen, and it connects here with the ligand. So let's say this is another now mutation or a problem. T helper 2 cell has a defective CD40 ligand. T helper 2 cell has a problem with the CD40 ligand molecule. So what would that mean? That would mean this co-stimulatory signal will not be produced. What would that mean then? That would mean B cell will not be helped by T cell to class switch. Now we talked about it, if B cell is not being helped for class switching, can it by itself work for the antigens or defend against the antigens? Yes. How does it do that? It would pick up things with the IgM and IgD and release IgM. So what would be the result? What will B cell be doing? It would receive a lot of pathogens, it would release a lot of IgMs. No one is going to come and help it to make IgG, IgG-D-E-N-A. Why do I keep saying D? D is already there. IgG-M-E-N-A will not be produced, only IgM will be there. IgM will be produced, that is produced without the need of T cell help. So that means the B cell would start producing increased amount of IgM, that is called Hyper-IgM syndrome. Hyper-IgM syndrome is not a B cell fault, it is a T cell fault at the CD40 ligand molecule. B cell is poor guy just trying to make more and more IgMs, nobody is class switching it, so it's just going to make IgM. Now what happens with the Hyper-IgM syndrome? Again, we don't have IgA. You would say, well, yeah doc, we also don't have IgG and we also don't have IgE. Too bad. IgA is the one which is protecting the surfaces, so the first symptoms are going to appear on the surfaces. So again, what are you going to see? You're going to see recurrent otitis media, sinusitis, pulmonary infections. This is very similar to the Bruton's Agammaglobulinemia. Why? Because here there are no B cells making the immunoglobulins. Here is B cell sitting idle, only making IgM but no immunoglobulin. In both cases, IgA deficiency would show up in the syndromes, in the symptoms. Cool? So they would look alike. However, in this case, IgM will be present, T cells will be abnormal, B cells will be normal. In this case, Bruton's, there will be no B cells. And if there are no B cells, there will be no IgM or nothing else. So that is how you can differentiate between them. Okay, so let's continue. The other one here is Wiskott-Aldrich Syndrome. Wiskott-Aldrich Syndrome is actually a B cell and T cell, it's a combined deficiency, but basically what happens is that T cells are not able to help B cell make immunoglobulins. So once again in this case what would happen is that the B cells will be present and will be making stuff, but because this is a combined deficiency, even B cells will not be making good immunoglobulins, all they will be making will be some IgM, so low amounts of IgM. Then there is the thrombocytes that are reduced, so this is very important for the Wiskott. There is the triad, and that is we have infections, eczema and thrombocytes. Why do we have eczema? We have low thrombocyte count, that causes the bleeding tendency, that creates eczema, and infections because there are low immunoglobulins. So that is Wiskott-Aldrich syndrome, combined syndrome, so low IgM and low T cells. Okay, let's see anything else here. We talked about hyper-IgM, we talked about Wiskott-Aldrich, that is hyper-IgM increase IgM, Wiskott-Aldrich reduce IgM. We talked about, so let's talk about selective immunoglobulin deficiency. So selective immunoglobulin deficiencies are most commonly two types of deficiencies, IgA deficiencies or IgM deficiencies. Here the most common one is IgA. If you see here once again, if IgA is less, what would happen? You would see the sinusitis and the pulmonary infections, you would see otitis media as well. Then is the Ataxia Telangiectasia. This normally appears in 2 years of age, hereditary, genetic, DNA repair enzyme has a problem. What happens is IgA is less, also lymphocytes are less. Why? Because this DNA repair enzyme is responsible for the repairs that is going to give rise to the lymphocytes. So mostly lymphocytes themselves are less, IgA is less, there are cerebellar issues as well, and there is blood vessel telangiectasia. So there are bigger vessels that should be small are bigger, and so you would see the telangiectasias in the face, and normally chronic giardiasis is an indicator. So that is the Ataxia telangiectasia. Okay, come down here. This was the B cells. Now let's continue with the T cells. We saw the first one here, IL-12 receptor deficiency that created the disseminated mycobacterial infections. Now let's reach here. We have the T helper cell that is functioning, it is working with the macrophage, giving it interferon gamma. If T cell T helper 1 reduces the interferon gamma production, then we end up having Job syndrome. Again now in Job syndrome what would happen is T helper based macrophage activation, which is a very important mechanism to kill intracellular pathogen, would be gone. When that would be gone, what do you think would happen to this side? All the pathogen burden will be exposed to the B cells. And what would they be doing? Nobody is class switching them. Why? Because we are coming towards this side, this particular pathogen, for example, Mycobacterium leprae. This particular pathogen moves us on this side. So ideally we should be killing it with the macrophages. So we have gone here. This leg is not going to be activated. So what is happening now? This is not activated because that is normal function. It should be cytotoxic. This leg is activated. However, interferon gamma is not present, so macrophages are not working. So at the end of the day, pathogen is sitting out there inside the cells and creating the immunogenicity. So now what happens is B cell is exposed to all that antigen and pathogen. The result is it would release a lots of IgE because that is all it can do. So that is the job syndrome. It is class switching with whatever little thing that is happening. In case of Mycobacterium leprae, actually what happens is that instead of going this path, it actually starts going this path. So there is class switching and IgE would increase. But anyways, job syndrome, increased immunoglobulin when interferon gamma. So this leg fails and this leg becomes more active. Let's continue going here. If you see this one, this is the IL-2 receptors. When IL-2 receptors are failing, or when MHC1 receptor fails, or when there is B cell and T cell in general, they fail together, that is called severe combined immunodeficiency. Why do we say combined? Combined means T and B cells both, and severe because it really the patient has no immune system at all. And what happens is normally in 6 months of age. Why? Because up till 6 months of age, maternal IgGs are present. Remember, IgG look like tummy, pregnant tummy. IgG can cross the placenta, go into the body of the fetus, and so baby is protected in the initial years, initial months, by IgG that came from the placenta, and then IgE that would come from maternal colostrum or the milk. However, after 6 months, when the IgG goes away and baby is supposed to make his or her own IgGs, that is when the disease would start appearing and infections would appear. So what would happen is at 6 months, baby will be presented to you with the failure to thrive, recurrent infections, diarrhea, recurrent diarrhea, viral, bacterial, fungal, protozoal infections. So this would be all kinds of infections. No T cell, no B cell. So all kinds of infections will be appearing. Many types of failures. Adenosine deaminase normally is less. That causes the MHC1 and MHC2. So this is MHC2. This is MHC2. So MHC2 failure, MHC1 failure, T cell receptor, interleukin cell receptors. These are all SCIDs, severe combined immunodeficiency. So more than one systems are failing. So that is the SCID. Let's see what else is here. Okay, so this is the B cell side, cytotoxic side. Let's talk now the last row here, which is the macrophages or the phagocytes. So in the case of phagocytes, there are two important things to remember. One with the both with the neutrophils. One is the Chediak-Higashi Syndrome. So what is that syndrome is that once the phagosome is taken in, then we bring the lysosome near it, then we combine them or fuse them. In the Chediak-Higashi Syndrome, the transport proteins are defective. So this fusion does not occur. This fusion, the coming together of these things does not happen. When the fusion does not happen, the pathogen is not really killed, and that would cause recurrent infections. With what? Intracellular pathogens. So that is the Chediak-Higashi Syndrome. Then, so again, this is a genetic thing, a transport protein is defective. Then if you see chronic granulomatous disease, normally appearing at 2 years of age, chronic granulomas, recurrent infections and granulomas. Granulomas with what? Viruses? No. Extracellular bacteria? No. Intracellular bacteria, which would need to be killed by neutrophils and macrophages, and they would need the activation. That is where it would appear. So now what would happen is that normally NADPH oxidase is not present, or it is defective. Now when the NADPH oxidase is defective, what happens is that the system fails. However, intensity can vary. So now when the bleach is not formed, pathogen will not be destroyed. Nitro blue tetrazolium test is positive. That is when you put some neutrophils in a test tube and then you try to do the oxygen burst. There is no oxygen burst, and so granulomas are produced. So CGD is there. What else? We talked about DiGeorge. Okay, one last one, chronic mucocutaneous candidiasis. This is actually helper T cells. So if you talk about this T cell, T cell, T cell, when the T cells are deficient for whatever reason, then there is chronic mucocutaneous candidiasis. Now I know that in here we talked about it. In the DiGeorge syndrome, we'll have Candida thrush and the respiratory infections, repeated infections. So that is it. This is how you can look at the overall bigger picture. Please make the same diagram. I will now erase the pathologies and draw the pharmacology in the same picture, and we'll talk about pharmacology of the immune system. Thank you. Okay guys, I forgot to mention the leukocyte adhesion deficiency disease. So what happens is that when there is a problem in the tissue, leukocytes, white blood cells, they have to come out of the blood vessels and go into that area and work there. Now I hope you remember, there is rolling, and then there is tight binding, and then there is diapedices, and then there is chemotactical movement towards the area of the damage. Part of the rolling is when there is sialyl-Lewis X protein, and that combines with the selectins, E-selectin and P-selectin, that is rolling. After the rolling comes a tight binding in which the neutrophils or the white blood cells, they combine their LFA1 molecule with the IgM1 molecule on the endothelial surface. So this is integrin, and these are the integrins as well. I've put selectin here, that is wrong. So the B2, beta 2 subunit, which is CD18 protein, this with the alpha unit, they combine with the IgM1, and that is how the tight binding occurs. After that, PCAM1s from the endothelium and from the white blood cells, they would connect, and the diapedices would occur. Extravasation would occur, and then the diapedices. Now leukocyte adhesion deficiency means there is a genetic problem, there is a genetic issue where the CD18 protein is not produced correctly. So what happens is that leukocytes are present in the body, they would stay in the blood vessel, they will not go out and help the area where there is pathogen and pick up the damage, care for the damage. So what would happen is severe pyogenic infections. By pyogenic, what I mean is severe bacterial infections. They are not really pyogenic. Why? There is no pus. Why? The pus is not normally present because it is the function of the inflammatory tissue in addition to bacterial damage to create the pus. So because the white blood cells are not extravasating from the blood vessels and into the tissue, there is no white blood cell or neutrophil to take care of the problem, so there is no pus there. The other indications at the birth, umbilical separation is delayed, and then you would see neutrophilia. Why do you see neutrophilia in this? The neutrophilia, because the neutrophils would stay in the blood vessels, they would not go out, so when you measure them in the blood, there will be a lot of neutrophils. However, they are not going to the tissue because they cannot tightly bind and stop, and so they cannot go into the tissue and work. So that is the leukocyte adhesion deficiency, a very, very high yield for the USMLE test.